Welcome to our discussion on advanced trauma care principles in the ATLS MCQ compendium by Dr. Atef Ahmed. Let's dive into the world of trauma, where every second counts and every decision matters.
Absolutely. It's a treasure trove of guidelines, from airway management to spinal and thermal injuries.
Right. So starting from the preface, we see that the ATLSR principles represent the gold standard for trauma care. It's like a foundation where rapid assessment, as you know, the ABCDE sequence, really saves lives.
Yeah. And it's interesting because proficiency in these protocols is essential for anyone in trauma or emergency medicine. And the idea of active recall through MCQs really reinforces learning.
True. And what's cool is how the MCQs delve deep into clinical application. For instance, questions about the primary survey emphasize that airway management with cervical spine protection is always the first, most immediate step.
Exactly. I mean, when you look at the question regarding the highest priority in the primary survey, the correct answer is airway maintenance with cervical spine protection. Can you imagine? One wrong move and the airway is compromised?
Yeah, it's like putting on your seatbelt before you start driving, right? You need to secure the airway first before you even consider circulation.
Yep. And then there's the section on airway adjuncts. For example, the contraindication of a nasopharyngeal airway in suspected basilar skull fractures clearly shows how important anatomical understanding is.
Absolutely. When a patient has signs of a potential basilar skull fracture, inserting an NPA can be disastrous because it can inadvertently go intracranially. It really underscores the need for careful assessment.
Now, moving from airway management, what do you think about the discussion on shock? The MCQs really highlight that tachycardia is the earliest sign of circulatory compromise.
Yes, and I found that particularly interesting. While many might expect blood pressure to drop first, the body's compensatory mechanism kicks in with a rapid heart rate. It's kind of like the body's early warning system.
Exactly. And then we get into fluid resuscitation. The idea of starting with a liter of warmed isotonic crystalloid is standard practice, but it's also a cautionary tale. Too much fluid before hemorrhage control can actually be harmful.
Right, because overzealous fluid resuscitation might disrupt clots and worsen bleeding, especially in penetrating trauma. It's interesting how the balance between restoring perfusion and not popping the clot becomes so delicate.
And then there's the chapter on thoracic trauma. The MCQs go into detail about recognizing tension pneumothorax. You know, those classic signs. Hypotension, distended neck veins, and tracheal deviation.
Right you are. And the immediate management, like needle decompression, is critical. It's a scenario where waiting for imaging could be fatal. It's like you just have to trust your clinical instincts.
Yeah, and later on, the discussion on cardiac tamponade with Beck's triad really illustrates the need for rapid intervention. Using FAST in the emergency department to make that call is a game changer.
Exactly. The FAST exam simplifies the detection of pericardial fluid and accelerates decision-making. It's all about saving time and ultimately lives.
Right on. Now, if we pivot to abdominal and pelvic trauma, the workup is quite pragmatic. For instance, the spleen is noted as the most frequently injured organ in blunt trauma, which is fascinating given its vulnerability.
Yes, and the MCQs make it clear how a seatbelt sign raises red flags for hollow viscous injuries too. It's like each external sign has a corresponding internal risk, and recognizing that linkage really matters.
Also, the importance of not rocking an unstable pelvis to avoid dislodging clots is a subtle but vital point. Precision in handling these injuries is paramount.
Totally. And then we see strategies like applying a pelvic binder to reduce retroperitoneal hemorrhage. It's A brilliant example of how simple interventions can have a profound impact.
Absolutely. Head trauma is another huge segment. The emphasis on preventing secondary brain injury rather than trying to reverse the primary injury is a critical tenet.
Yeah, definitely. It's fascinating how the focus shifts to securing cerebral perfusion. Avoiding hypotension is more than just a number. It's about the brain getting enough blood flow.
Right? And the discussion on the Glasgow Coma Scale is equally compelling, especially the part on how the motor response is the best predictor of outcome.
True. And these details are not only theoretical, they guide real-time decisions in the trauma bay. For example, a blown pupil immediately alerts us to the possibility of uncal herniation.
Exactly. Speaking of herniation, the recommendations to reduce intracranial pressure with agents like mannitol and even the temporary use of hyperventilation, though with caution, really underline the urgency in TBI management.
Indeed. And then there's the issue of spinal trauma. The book delves into concepts like neurogenic versus spinal shock. It's detailed and reminds us that a cervical fracture might coexist with other vertebral injuries.
Definitely. Plus, the nuances between the different spinal cord syndromes, like anterior cord syndrome sparing dorsal columns, really sharpen clinical reasoning.
Totally. It's behind-the-scenes reasoning that helps predict prognosis and plan management. The guidelines also challenge outdated practices, like using high-dose steroids in acute spinal injury.
Absolutely. Then we get into musculoskeletal trauma. Here, the emphasis on hemorrhage control, especially in fractures like pelvic or femoral fractures, is paramount.
Right, massive hemorrhage is the most immediate threat, and the approach with traction splints for midshaft femur fractures not only realigns the bone, but reduces bleeding and pain. It's like a double win for stabilization.
Yeah, and let's not forget the details on compartment syndrome. The early warning of pain out of proportion, especially with passive stretch, is key to preventing irreversible damage.
Yes, because waiting for lost pulses is way too late. It's a reminder that early recognition and fasciotomy are life and limb saving.
Exactly. Now, thermal injuries add another dimension. The guidance begins with the immediate priority: stopping the burn process. It's not just about covering up the burns, it's about cutting off the cause first.
Right. Removing smoldering clothing and stopping further exposure is absolutely crucial. And then, the fluid resuscitation formulas for burns, 2 ml/kg per percent TBSA, offer tangible steps in management.
Absolutely right. And the method of administering half the fluid over the first 8 hours post-injury versus the remaining 16 hours really paints a picture of how timing is everything in resuscitation.
Yep, and it's like a balance between restoring volume and avoiding complications like fluid overload or worsening edema.
The section on inhalation injuries in thermal trauma is also crucial. Recognizing facial burns and soot in the airway quickly guides us to secure the airway early before edema sets in.
Right. Early intubation is emphasized because waiting can sometimes lead to a situation where you simply can't intubate due to the progression of airway edema.
Exactly. Lastly, the book wraps up with sections on special populations like pediatric and geriatric trauma, as well as differences in pregnant patients. These nuances really remind us that one size does not fit all in trauma care.
Right. For example, children's more pliable bones and higher surface area to mass ratio make them more prone to hypothermia, but also less likely to fracture in the same way as adults. It's all about adjusting our approach.
Yep, very important. And the emphasis on maternal stabilization in pregnancy, because the fetus depends entirely on the mother's well-being, is a really powerful reminder of prioritizing care.
Exactly. It reinforces that our interventions, whether in the field or hospital, need to be adapted to each patient's unique physiology and circumstances.
Absolutely. Before we wrap up, I want to respectfully challenge one nuance. Some might argue that the focus on detailed MCQs might oversimplify real-life decision-making. What do you think about that?
That's a good point, but I'd say that these MCQs are like practice drills. They create a framework for thinking, even though, in the moment, decisions can be more complex. It's not a substitute for hands-on experience, but it certainly bolsters our critical
Right,
thinking.
I see that. It really is like a simulation of how we must prioritize assessments and interventions, from airway to circulation and everything in between.
Exactly. These questions serve as reminders of the best practices we rely on in true trauma scenarios. They refresh our memory on targets like proper airway adjuncts, shock management, and rapid recognition of thoracic, abdominal, and neurologic injuries.
Very true. And with that, it's clear that this resource by Dr. Atef Ahmed not only reinforces current guidelines, but also challenges practitioners to keep learning and refining their skills.
Absolutely, continuous education in trauma care is vital. It's like our commitment to saving lives starts with being prepared and knowledgeable.
Yep, couldn't agree more. That's our deep dive into the content today. It's been an enlightening conversation that spans from the basics to the intricate details of trauma care.
Indeed, thanks for this engaging discussion. And remember, as the guidelines emphasize, it's not just about passing an exam, it's about applying this knowledge dynamically in the face of real, life-threatening situations.
Absolutely. Until next time, keep learning, stay prepared, and take care in those high-pressure trauma situations.
Thanks for listening, everyone. Stay safe out there and keep those skills sharp.